Good morning, I'm Miguel. I'm presenting on ARDS. Quick outline, I'm going to be talking about the Berlin definition of ARDS, the epidemiology, pathogenesis, interventions, and some of the outcomes. The Berlin definition was developed in 2012 to better identify cases of ARDS. It has four components, first being timing. Within 1 week of known clinical insult or new or worsening respiratory symptoms, with the chest imaging, looking for bilateral opacities, not explained by effusions, lobar lung collapse or nodules. Origin of the edema is not cardiac failure, fluid overload. And as Trevor mentioned earlier, for her oxygenation, different severities. PF ratio of 200 to 300 is mild. The moderate is between 100 and 200, and severe below 100. The mortality associated with them for mild is 27%, 32% for moderate, 45% for severe. There's still some difficulty in identifying ARDS. It's mostly lack of agreement when people are looking at the chest x-ray. Clinical recognition rates for mild ARDS are about 51%, 78% for severe. Just some of the risk factors for ARDS. Pneumonia accounts for 35 to 50%. Non-pulmonary sepsis is about 30%, and aspiration and trauma are 10% each. Just some of the chest x-rays with the bilateral opacities. The CT scans show that the infiltrates are predominantly in the dependent regions. For the epidemiology, there's about 200 cases a year in the U.S., 200,000 cases per year in the U.S. with 75,000 deaths. Lung Safe trial looked at more than 29,000 ICU patients. There was a 10% prevalence, 40% mortality, with a 23% prevalence in patients that were intubated. Quickly going through the pathogenesis, there's three phases: exudative, proliferative, and fibrotic. The exudative phase is just activation of alveolar macrophages, for release of pro-inflammatory mediators, accumulation of neutrophils and monocytes, and damage to the barrier function, leading to interstitial and intra-alveolar flooding. The proliferative phase aims to restore tissue homeostasis. There's expansion of fibroblasts and formation of a provisional matrix. And lastly, fibrotic is the one that's strongly associated with the need for mechanical ventilation. There's basement membrane damage and leads to the development of interstitial and intra-alveolar fibrosis. For interventions, the first one is to address the underlying pathology. There's not many proven interventions. The ARDS trial was the one that started the lung protective mechanical ventilation of 6 mLs per kilogram. I compared 6 to 12. It was about 10 academic centers, 75 ICUs looking at 1,000 patients. Showed a reduced mortality by 22%. The reduced tidal volume, it limits volume trauma and atelectic trauma. Another intervention is prone positioning for patients with a PF ratio less than 150 for at least 16 hours a day. It's thought to facilitate more homogeneous inflation and more uniform distribution of mechanical forces throughout the injured lung. In mild ARDS, the PF ratio is between 2 and 300. Helmet non-invasive ventilation has been shown to reduce rates of intubation and 90-day mortality. It's thought that it's more comfortable, there's less air leak and less risk of aspiration. There haven't been many or none pharmacologic interventions. Looking at aspirin, it was thought that platelets might play a role in the development of ARDS. There was a trial looking at emergency room patients that were high risk. Given aspirin, there was no reduction in the development of ARDS within 1 week. The beta-2 agonists thought they might reduce alveolar flooding. This was an increased mortality at 28 days, with growth factors possibly accelerating alveolar epithelial repair. Again, higher mortality at 28 days. Statins, I was thinking that it might reduce inflammation and progression of lung injury. There was no significant differences between two groups. With high-frequency oscillation ventilation and lung recruitment maneuvers, there was no improvement or increased mortality. With the CO2 removal, with the goal of reducing tidal volumes from 6 mLs to 3 mLs per kg, there was no difference in vent-free days, but specifically in patients with PF ratios below 150, there was actually a reduction, and there's 2 active trials looking at this method now. I forgot to include steroids. They're not recommended in ARDS, and high-dose steroids are associated with increased mortality. For the outcomes, the patients that are discharged after ARDS at 1 year, as 45% had neurocognitive impairments. At 2 years, about a quarter of them had symptoms of depression and anxiety. At 1 year, the distance walked in 6 minutes was less than predicted. On lung function testing, there's a mild restrictive pattern after someone has ARDS. This chart just shows some of the variables that are less than predicted at 1 year. In summary, not many proven interventions for ARDS besides treating the precipitating process, lung protective ventilation, prone positioning. This is just like a cheat sheet for the ARDS NET trial. It's on WikiEM. It has the inclusion criteria as a ventilator setup, how to calculate predicted body weight, and how to achieve some of the goals, specifically for the oxygenation, the PaO2 between 55 and 80, some of the combinations of PEEP and FiO2 you can use, and also keeping the plateau pressure below 30. Some of the things you could do to change that. And with acidosis below 7.3, you can increase the respiratory rate to 35. You can also increase the tidal volume by 1 ml on small steps. And lastly, just some tips for weaning and having a spontaneous breathing trial. I wanted to thank Dr. Tan, Dr. Delgado, Dr. Kendall, my references. Any questions?
So I think it's really important to when you're starting out, when you're hypoxia, you're trying to fix the hypoxia. You don't just go up on the FiO2 to get to 100% and then go to PEEP. There's actually that table you just put up there. It's really important to know. It's actually taped to the wall in the trauma room in CCT on the back wall. If you guys ever want to look at it, I put it there a couple years ago and they haven't managed to take it down yet. So it's in the back wall there, but follow it when you're trying to increase their oxygenation. Don't just crank up the oxygen, it's not good for their lungs.
And remember, right, you don't have to be at 100% saturation for these patients, right? You're just trying to do the least amount of damage to this patient's lungs while you're fixing whatever stress put them into areas in the first place. So just like there are plenty of other conditions, COPD and things where you can tolerate lower FaO2 to have more lung protection, this is one of them. So you want to get these numbers kind of in the sweet spot, and if things are just a little bit off, that's okay. Especially in severe ARDS, it's hard to get everything perfect when you're trying to manage so many different elements of damage to the lungs that can happen when you're doing mechanical ventilation.
Yeah, re-expansion pulmonary edema looks just like this. I find that the longer the lungs are down, the higher the chance of having re-expansion pulmonary edema. It's not just how bad you blow it up, but it's how long the lungs are down. So that's to do with how much surfactant is in the alveoli. And when they're crushed down, they don't have that much surfactant lining the walls evenly, so they don't tend to stay open.
For mentioning with the plateau pressure, the runner freaks out about the peak inspiratory pressure, but that's not the number. Plateau pressure is not on the bend. You have to do a whole. Yeah. So that's not the number on the screen. Is not the pressure you're worried about. When you remember this protocol.
Yeah, each vent has a different way to do a hole. I have to look at it specifically to go over it and to see how to do it. But the purple vents, I believe it's a little bit more difficult. It takes 2 steps or 3 instead of just the 1 on the colder vents.
And there's no monitor on the purple ones, right? There's no screen. So that's why they're great for transportation, but they're really crappy for managing critical patients on their
Yeah, nice transport ones.
Yeah.
I just want to add, like, ARDS, obviously bad, but there are different causes of it. Always look for your underlying condition. And just because this has happened, to me, what I would say is if you have younger patients with ARDS and they tend to be getting worse. You know, your role with the ventilatory management is not to cause any more damage, but these are also patients that you may want to consider calling for possible transfers in ECMO because if it's a young patient who has influenza and ARDS, they might have a significant chance of overcoming that, but you're not going to be able to manage them here without something like ECMO. Old lady with multifocal pneumonia and ESRD, maybe not as much, but just consider that because you guys do off-service rotations and NICU, SICU. It's never going to hurt to bring it up because we have had some success stories with that where they were going downhill with us, even though we were managing them appropriately.
Yeah, proning works decent, but one of the things to consider also changing to a pressure-regulated mode on the ventilator, which I think is a whole other lecture way above our level, but it's something to think about as you talk to the ICU people about.
All right, thank you.